So I want to first start with the background and state that clinical trials accrue poorly. Less than 7% of eligible patients actually enroll into cancer clinical trials. And we hypothesize that financial barriers likely play a role in this lower enrollment among patients with lower financial issues, specifically minorities, uninsured patients, and those with lower socioeconomic status patients that are less likely to be represented on cancer clinical trials. And there's more and more evidence that cancer care in general causes financial burden for patients. Cancer patients are more likely to file for bankruptcy than those with other chronic conditions. Patients with financial burden are also at risk for potentially harmful cost-coping strategies, which include not filling prescriptions, not coming to appointments in order to save on their cost. And we also hypothesize, and it's probably true, but it hasn't actually been proven yet, that clinical trial participants represent a population that may be particularly vulnerable for financial toxicity, mainly because they're having to come more often for clinic visits and for other labs and other testing that may not be a part of standard care. And so we say this was the reason for the current study, that there is a need to address the financial burden of the clinical trial participants. Most of the literature currently, when they talk about the cost of clinical trials, usually focus on the cost to those that are conducting the study, like sponsors, payers, and the institutions. And trial participants actually endure, as I was mentioning before, frequent clinical visits and travel to the trial sites, which may increase the cost that they have to bear. And while the Affordable Care Act notes that routine care must be covered by patients on clinical trials, these patients are still having to pay for the extra visits, the co-pays, the travel, the lodging, the meals, etc. Thus, Massachusetts General Hospital partnered with the Lazarex Cancer Foundation in 2013 to create this cancer care equity program. I'll call it the CCEP from now on. And it consists of these three components. And we're here to talk about the research component of the final portion, which is the financial assistance piece. But the three components are the community outreach, which is to try to actually educate patients more about clinical trials and about the options that are available for them, and to bring patients into Mass General and to help patients to take part in the clinical trials here from the community. We also have a patient navigation piece, which has mainly been focused to this point on cancer screening, mammography, colonoscopy, et cetera, and follow up on those results. And then this current study is looking at the financial assistance piece, where we help patients with the travel and lodging portions of the clinical trial that they're participating with. So how do patients get involved with the CCEP? They first have to be enrolled in or screening for a clinical trial, so we can't necessarily tell patients before they come and start to think about a clinical trial that this is an option. We don't want to coerce patients into coming to Mass General just so that they can get this assistance. Once patients are referred, they're usually referred by their oncology provider, the nurse, the infusion nurse that's seeing them, the research coordinators. They're then sent to the Lazarex Cancer Foundation, who determines their eligibility and helps with reimbursements, and they do this on a monthly basis. And us, as the CCEP program, we're here to liaise with the Lazarex Cancer Foundation, ensure that patients get their reimbursements, and help patients throughout the process, and ultimately do the research on this aspect. So the study objectives with the current study was we went into this is the first attempt to try to understand the impact of the Cancer Care Equity Program. We've been doing this for over a year now, so we thought it was time to look and see, are we actually making a difference in helping with clinical trial enrollment here at Mass General? We wanted to compare participant characteristics after the implementation of the program, and we also wanted to look at the differences between the patient characteristics of those that were on our program and those that were not during the period where the Cancer Care Equity Program was up and going. And we also asked patients about their patient-reported barriers to trial participation. This was a survey, and we'll talk about as well. So the study design we used is an interrupted time series design. We wanted to look at the clinical trial population up to 2013, so from 2005 to 2013, and then beyond in 2014 and beyond after the implementation of the program, to look at the clinical trial accrual rates over this time period. So in order for statistical analysis, we fit a linear regression and looked at data from the 2005 to 2014, and we used this interrupted time series design to tell if there was a difference between before and after, with the term for the CCEP being within this linear regression model, to see if we've made a difference with this program from the time period beyond the CCEP implementation. And we also examined annual differences in patient characteristics with univariate and multivariate analyses. I'll mainly talk about the univariate analyses today. And within 2014, we compared the patient characteristics of those within the program and those that were not in the program. So I'll go through the study schema throughout the rest of the talk. There's these three portions that we're going to go through. The first is just looking at clinical trial enrollment from 2005 through 2014 and the differences between the patients and how the numbers have changed over time. So this is first just comparing the prior to the CCEP to after the CCEP, and we show here some of the different demographic features. The only thing mainly different here is that the insurance differences were a little bit different between before and after. We also looked at the differences between the cancer types, those with metastatic disease, and the different trial phases. And what you'll see here that's interesting is that in the newer year, 2014, the most recent year, there's more patients on phase 1 clinical trials, which is to be expected here. And this is the primary outcome from this study. So what we've got here is this is more of a pictorial version of the linear regression model that we've created. And what you can see over time in the dark blue there are the dots that are connected per year. And so over the time, you can see the clinical trial accrual is continuing to increase at Mass General, which we would hope for and expect. Interestingly, we noted last week that the year 2008 was actually quite lower than the other years, which also is interesting because 2008 was probably part of the economic downturn in America, and you wonder if that's actually hinting at something going on there where people weren't doing as well financially, and so there were less people enrolled on clinical trials. That's interesting. But most noteworthy here is what you can see is in light blue shading here is the prediction interval. So what we would be expecting patients or where a point may lie for the next year. And what we see in 2014 is that our point in our clinical trial accrual far exceeds what we would have expected if it was following this same regression line. So next we wanted to look at within 2014 the patients that enrolled in the program versus the patients who did not enroll in the program. So we've got here 153 patients were enrolled in the CCEP in the year of 2014 compared to the just over 1,000 patients that were not. And so again, we looked at the same demographic characteristics, and this time there's other more significant features. So I think based on what I can tell, yeah, there was more female gender in the CCEP program, and we also had a trend towards increased Hispanic ethnicity. We also noted here that the income was significantly lower among the group that we enrolled in the CCEP program, which is part of what we were hoping to enroll as a patient population that needed the assistance. Additionally, we looked at differences in the cancer types, and we did find a difference in the rate of accrual for cancer types. It's interesting. It's probably really related to the clinicians who are referring to the program. And so what this shows is that thoracic and breast cancer groups were doing a good job of sending patients our way, but the genitourinary and GI groups potentially have some room for improvement. Also notable here is that we had an increased enrollment among the phase 1 clinical trial patients, which again was not necessarily a goal of the program, but we have our hypotheses about the fact that potentially phase 1 clinical trial patients may be more at risk for financial burden if our hypothesis holds true that clinical trials in general may lead to financial distress. And so I added this slide just to mainly show how much we're reimbursing patients that are a part of the CCEP program. And so the patients, we divided them up among local, regional, and national. National patients being beyond the New England area, regional patients being within New England, and local being within Massachusetts. And what you can see is that even among the national patients, on average, we're reimbursing them about $900 per month. And what we wanted to really hammer home with this statement was that this is not a huge amount that we're having to reimburse patients. It's not a lot that's actually necessary to help these patients with their burden, yet this probably represents a fraction of what it costs to run an entire clinical trial. So something to think about, and we'll get to in the conclusions as well. The next step was that we wanted to look with surveys about the barriers that patients may be experiencing whenever they think about enrolling in a clinical trial and whether financial issues are a concern. So we mailed surveys to all English-speaking participants who were enrolled in the CCEP, and then whenever we got a survey back from one of our CCEP participants, any participant we wanted to match with a per gender, per the year enrollment, and per the particular clinical trial. So we sent to a non-CCEP participant with those matching criteria in order to truly tell was there a difference between the financial burden between the two groups. So this is the final part here. We had a pretty good response rate. These were mailed surveys, and it was over 60% response rate in both groups. So this is our findings here, and what is in the darker color on top are the CCEP participants, and then in the yellow is the non-CCEP participants. And what this shows is that across all of these questions, the CCEP participants were more likely to report financial concerns. They're more likely to report concerns about the cost for the clinical trial, more likely to report concerns about covering the medical coverage for the clinical trial. They're more likely to report that they were worried about affording medical costs and afraid that health insurance wouldn't cover. So most of these, it's interesting to note that even the non-CCEP participants, around 10%, were reporting some sort of financial concern. So in summary, after we implemented the CCEP at Mass General Hospital, we noted that clinical trial participation increased greater than what we would have been expecting based on our regression model. And the CCEP served a population that was particularly in need of financial assistance. They were younger, had lower incomes, and were traveling a farther distance to get here. And our surveys also illustrate the financial concerns of the patients who were enrolled on the program. So some of the limitations that are worth noting was that this was just at a single institution, and we cannot definitively conclude that the CCEP caused the increase. There were probably other things involved that we couldn't control for, but we can state that there is a strong association, and with the information that we saw about the patient characteristics. We think that we're helping a population that was needing assistance. We also lack information about whether the CCEP altered the cancer care team's decisions to refer patients to trials. Again, this was patients that were already referred to a clinical trial before they even were particularly available to get CCEP assistance. So it's hard to know that we were really adjusting the oncologist's decision to refer patients. And we also don't really know at the current time, this is the subject of future study, whether or not the CCEP impacts the financial burden experienced by these patients. And we would like to look longitudinally over time. So in conclusion, costs represent a barrier to clinical trial participation based on what we've seen. The CCEP also represents a novel way to potentially improve trial participation. And in the future, we hope to continue to address the financial issues experienced by these patients. We also want to develop tools to identify those that are needing financial assistance, and that's also the subject of our future study right now too, is developing a financial questionnaire that helps to not just look at objective issues like cost and out-of-pocket costs that people are experiencing, but also the subjective issues that patients are having and experiencing distress related to the cost that they're experiencing. And we also hope to encourage key stakeholders to support and remove financial barriers to trial participation. Again, going back to that slide about the amount of money that it costs in order to reimburse these patients, and potentially the amount of money that it costs to conduct a trial, and is it worth helping with somewhat of the reimbursement or some sort of a third party like the Lazarex Cancer Foundation in order to help improve clinical trial accrual. I want to thank, most importantly, the Lazarex Cancer Foundation, which is Dana and David Dornzeif, and then Tammy Keeler has been helping us with liaising with the Lazarex Cancer Foundation. My fellowship mentors could not be better, and I can't thank them enough for all the help that they've provided me, and our patients and the trial participants. And thank you guys.
Waiting for him
Well, I just had a quick question. You had an increase in enrollment, but that seemed out of proportion to the fraction of patients that you're enrolling in this program, right?
The number of patients that we're actually enrolling in the program?
Yeah.
Correct. That's why we've had a hard time with just 153 out of over 1,000. Were we truly making a difference? And that comes back to, are we actually somehow, and we actually are going to try to do this with more qualitative work, interviewing the oncologist, and are we somehow helping with the oncologist's decision to refer patients, whereas they may not have sent somebody to a clinical trial if they knew they weren't going to be able to afford or to be able to make all the appointments. Maybe they weren't willing to usually send that patient, but now that they know that we have this program available, they're more likely to discuss a trial with a patient and potentially send them our way.
Or did you make it easier for them to refer?
Exactly.
By setting up
someone that could
hotline
actually.
or a...
So we have a liaison. So our main financial assistance provider is someone that works for both us and the Lazarex Cancer Foundation, who is fantastic and gives the patient someone that they can discuss with and help get advice on whether or not they can get reimbursement and what do we help with and how much is available to them. And so that's another potential way that we're helping facilitate increased. Maybe we're helping with the oncologist attitudes towards sending patients to clinical trials.
And you didn't have 50 more trials this year than last year.
So we did. That's interesting. We do. We every year we have more and more clinical trials, and we've done different models, and we have in previous models controlled for the number of trials that were available that year, and this still holds actually. So that's one thing we did control for in other models that does hold. We haven't been able to control for all the other factors, the gender, the age, which may actually also be playing a part, but the clinical trial actual availability we've looked at and it still holds.
All right.
So you looked at income as a kind of a marker for who needs financial assistance, but it's a little bit of a crude marker. What's your next step in terms of trying to figure that piece out, because we're all struggling with it?
It's actually a very crude marker. So we've actually have our own hypotheses that we've been discussing in our group about perhaps there's actually the safety net. Maybe people that with much lower incomes are okay, and that people with much higher incomes are okay, and maybe we're missing this middle ground population that may need the assistance. And so that's why we've developed a questionnaire it's got out-of-pocket costs, which we also don't account for in this current study, and it's got more subjective questions. So there is there's multiple ways. There's simply how burdened are you by financial concerns, and 5-item questionnaire. That's one that's been used in the past. We're actually adopting another. It's a novel way of measuring financial toxicity. It's called the cost measure. It's an 11-item measure. It's not perfect, but it's kind of the only thing that's been validated thus far to look at financial burden. And so that's also a part of our future study. So at enrollment now, whenever patients come and get referred to us, we give them this long questionnaire with all these financial burden questionnaires. And we're also going to be giving it to them every 45 days while they're getting assistance to see if we're actually helping with both the objective and subjective financial burden.
But, the results of this really imply that a major reason why people don't enroll is because of the financial burden. And I don't know, other people think that that's, agree with the assessment, if that, as opposed to they're not getting referred for clinical trials, which is, I guess the reports I've seen suggest that people aren't getting referred for clinical trials as optimally as they should be.
One of the reasons they're not referred is that the doctor looks at the patient and says the patient cannot afford to make multiple trips and pay for a lodging. The other factor is that trials now are attracting patients from much longer distances away because of the unique subsets of patients we're looking for. And those patients, if they don't have a lot of money in the bank, may be very stressed to come.
There was a paper published last week in JAMA Oncology from the state of Washington where they specifically looked at patient incomes and whether or not they were referred to trials, and they found, they call it a new disparity, patient incomes for clinical trials. The patients with lower incomes were less likely to even be referred. So it's exactly what we're hypothesizing, and someone is showing it, so it was nicely done.